Good afternoon. First of all, let me thank the organizers once again for giving me this opportunity. So I'll be presenting on the other first-line NTRK inhibitor, this is larotrectinib. So it's actually the poster presented in ASCO this year. This is updated efficacy and safety of larotrectinib in patients with tropomyosin receptor kinase TRK fusion lung cancer, which is presented as a poster in ASCO. And we already discussed in detail about the NTRK fusions in general. So it's an oncogenic drivers in multiple tumor types. In lung cancer, it is the frequency is much less. It's less than 1% in most of studies, though some series say up to 3.3%. And we know NTRK has multiple fusion partners, and the alterations seen mainly in lung cancer include NTRK1 and NTRK3. And the most common factor translocation partner is TPM3, unlike some other tumor types. And also there is some data that it can be involved in the resistance to EGFR. So the major problem with NTRK in lung cancer is it's a rare alteration and there is significant diagnostic difficulty. So if you look at the common tumor types with common NTRK alteration, the guidelines are very clear. We can directly go for the targeted testing, either FISH or RT-PCR. But in cancers for the NTRK, alterations are less frequent. There is some confusion in the testing modality. So the ESMO guidelines say either you can go for IHC screening and then go for sequencing, or if there is access to sequencing, you can do a sequencing directly. But it's important that it should be RNA-based sequencing. So in this subtype of tumors, we have tumor agnostic approval with the first line larotrectinib and entrectinib. We have already discussed in detail about the entrectinib. And now we have newer agents like selatrectinib, repotrectinib, and taltrectinib. So this study, what I'm going to present is actually an update. The original paper was also published in 2022 only in JCO Precision Oncology. So this is the data from the two registrational clinical trials that used larotrectinib. So the phase 2 basket trial, the Navigate trial, and another phase 1 trial. So these trials has a primary endpoint of overall response rate, and secondary endpoints were PFS, OS, and duration of response. So the patients received 100 milligram BD larotrectinib as 28-day cycles, and the response rate by IRC independent review committee was the endpoint. So this was the poster that was presented this year. So this was the data from the expanded cohort. So initially there were 20 patients. This presentation had 26 patients. And 24 patients had non-small cell lung cancer, and 1 patient had a typical carcinoid, and 1 had neuroendocrine carcinoma. And 10 patients had a baseline CNS metastasis. So the median age was 51.5 years, and as expected, NTRK1 was more common than NTRK3, that is 81% versus 19%. And the median number of lines received were 2, and almost 73% had at least 2 lines or more treatment before they were enrolled in this trial. So they had around 23 evaluable patients, and the overall response rate was 83%. It was slightly higher compared to what was mentioned with the entrectinib. And 2 patients had CR, that is 9%, and PR was seen in around 17 patients, that is 74%. And the median time to response was 1.8 months. So in the patients with CNS metastasis also, response rate is impressive, that is 80%, and 2 patients had CR. And at the time of this presentation, that is median follow-up of around 13 months, the median duration of response was not reached. Median PFS was also not reached. And the 2-year duration of response of PFS was 72%. Duration of response was 72%, whereas the PFS was 67%, which is also impressive. And the overall survival remains at 72% at the end of 2 years, as well as 3 years. And with respect to CNS metastasis, though the response rate was similar, the duration of response was only 26% at the end of 1 year, and PFS was 22%, and the overall survival at the end of 1 year was 78%. And at the time of data cutoff, 6 patients progressed, and they are continuing on larotrectinib as they had clinical benefit. So this shows the plot for the response rates. So if you look at the light blue is the patients without CNS metastasis, and other indicates the CNS metastasis. The response rate are almost similar, so both you can see the both colors intermixed. But when you look at the treatment duration, so it's very clear that those patients who had progressed are those with CNS metastasis. And some of these patients, and those patients who are continuing after progression also mainly belong to this group. And the duration of response and PFS is definitely much higher with the patients without CNS metastasis. And these are the curves again. So median follow-up of 12.9 months. The 1 year duration of response is 72%, and 2 year is also 72%. And the median PFS is also not reached. And OS, as I've already mentioned, median OS is around 40.7 months, which is an impressive figure. And even 2-year OS is 72%. So coming to the toxicity, this is sort of a well-tolerated drug. So majority of the side effects are grade 1 or 2, which, as you can see in the diagram, that is blue and green. And very few patients had grade 3 or 4 treatment-related adverse effects. They included mainly increase in the liver enzymes, hypersensitivity, myalgia, weight gain. And none of the patients had to discontinue treatment due to toxicity, all discontinued treatment due to progression. So they concluded that in larger data set, actually larger compared to the previous publication, the larotrectinib demonstrated rapid and durable responses, extended survival, and a favorable long-term safety profile in patients with advanced lung cancer harboring NTRK gene fusions, including in patients with CNS metastasis. So these results support the testing for NTRK gene fusion in patients with lung cancer. So as we have seen, the response rate with this drug is comparable to any other tumor types, and it's even better compared to the other drug. And there is always a concern of larotrectinib having less CNS penetration. So the nervous system side effects are lesser. At the same time, there are concerns about the efficacy in the patients with CNS metastasis. Though the response rates are comparable, the duration of response and PFS is lesser. And also, like a first-line agent, there is on-target and off-target resistance concerns. So practically, it's a very rare mutation. We have to keep on looking for it. Definitely, there is a diagnostic problem. We have to rely on the RNA-based NGS. And access to drug, at present, we may have to depend on the compassionate programs. Thank you.